What about moving this into a community setting? What do you guys think?
Well, I think that's an important question. It's been raised by the commercial sort of arms of all of the companies doing these studies, because it'll be open to more patients. I think you have to start with centers that have a transplant program. I would say that as a bare minimum, partly because the requirement is that these be FACT accredited anyway, and so I think you have to have a transplant program. I would be cautious about this until we've got more data on managing toxicity. I don't think it's ready for that yet, but down the road, I think as we learn more about it, learn how to manage the toxicities better, it theoretically could be done.
I think in a community setting, what you'd really need is a setup that can handle it. In other words, many community practices, the oncologists are doing a variety of things, and they're not always accessible for the kind of, you have to be on the spot, you have to be intensely managing CAR T-cell type approach. But I certainly could envision a community setting, say, where they have a focused leukemia team or lymphoma team, where they have inpatient people who are on the floor all the time and can manage it, where they have an ICU that's been trained. So in that very specific
narrow
setting, yes, but you're either all in or don't do it, right, for CAR T cells. Right.
Well, nobody has mentioned that this is complicated. I mean, I guess we have, but it is complicated, yes, and you can't just get approved to do this just because you want to, right? There's this REMS program, which is quite difficult, and there's also the FACT accreditation, which seems to be increasingly for immune effector cells, which is increasingly being applied. What are you guys? I'm sure you guys are all dealing with all of this as well.
Yeah, we're already fully FACT accredited for effector cells, but that's expensive. It takes a huge regulatory apparatus in order to keep it up. You have to have quality that goes on and on. You have to have a very good apheresis team. You have to have a stem cell processing lab. So it's not trivial.
Yeah, at our institution, I think we had to train 300 and something people, not patients, right, people to be able to actually give these two commercially approved drugs.
Right. I don't know the number off my head, but just thinking about one patient to go from kind of the consultation through CAR T-cell, the number of people, resources that employees that think about that one patient to make that one CAR T-cell happen. In my mind, the number of 20, of discrete jobs that they will do to get that patient from the consultation into, through their CAR T-cell. It's a major deal.
So is this easier or harder than running a transplant center?
I think it's a really good question, and I think it's going to depend on the CAR, right? Because if we have, right now, even grade 2 cytokine release syndrome is tough to manage. Patients are getting tocilizumab. And so do you foresee managing CRS or neurologic toxicity as an outpatient?
I don't see happening.
I don't see that happening.
I don't see that happening either. Yeah, I think the important message again is that, if even just taking the ZUMA-1, if neurotoxicity, even early grade, neurotoxicity and CRS is in the order of 60s to 90%, the deaths were only 3. Which means that intervention really helped to convert those into manageable things where patients didn't have to die and could ultimately benefit. We see now in the real world experience from the 2 abstracts presented with about 400 patient data that the use of tocilizumab and steroids has been more, and that did not seem to have any effect, or at least I know in a non-randomized fashion, but did not seem to have an effect on efficacy. So people are trying to use these agents early on, but they have to be comfortable in identifying them early on. So the first headache or the slight change in mental status, the multiple neurochecks, slight hypotension, you miss that, then you're dealing with grade 3. So if you are not in a setting where you can pick these things up early and intervene early, then you're going to have to deal with a lot of difficult toxicities. And we just see that quick translation from and I'm sure this usage is just going to go up. And people just need to be comfortable, and also in many places to have doses of tocilizumab available before you give.
Well,
That's a mandatory
you can't
thing.
get past the REMS program unless you have it.
Unless you
have it
have it.
available.
So those are things which are very important.
I think you hit it correctly in, you said early symptom, but there's a difference between prophylactic. And I think there's a small experience with the Axicell at early prophylactic tocilizumab use that may have predicted for more high-grade neurotoxicity. So early, yes,
But
not
prophylactic.
prophylactic, no.
Less-
Right.
less-
I think we need to be careful with these algorithms. If we give it too soon, we may kill our effector
Right.
effect. And so if we're going to be changing the algorithms very dramatically, we've got to study it. We've got to have
But this does lead to a lot of problems, because if you actually look at the REMS programs, they're different for each of these products. In fact, they're telling you to do exactly different things at different times. And I think that what we're seeing now in the real world experience is that they're converging more towards an earlier adoption of intervention to keep people out of the ICU. But this is going to require some further education.
Yeah, if you get 3 constructs on the same floor, you almost need to have them, one patient's in blue, one blue
Yeah.
shirts, red shirts, green shirts.
Well,
to know.
It is
we
an
have,
interesting.
because with the studies, it's equally issue. You're supposed to manage it according to what your study says. We have different outlines for each study, and it's a
And
challenge.
when you add multiple diseases, just imagine the complexity.